This recorded lecture will be going over Chapter 12, the respiratory system, in the MedSurg textbook. Functions of the structures of the upper respiratory system. The mucous membranes secrete mucus. This traps dust particles and bacteria. A lot of this should be reviewed from our structure and function. We know that the epiglottis protects the airway, so when swallowing begins, the epiglottis closes over the larynx, preventing aspiration of food and secretion into the lungs. Food is then directed into the esophagus. And we can see this picture of the structures of the upper respiratory tract on page 257, as well as this picture of the paranasal sinuses on page 257. And again, a lot of this should just be a quick review from structure and function. Functions of the structures of the lower respiratory system. We know that after passing through the nose, pharynx, larynx, and trachea of the upper respiratory system, air will then enter the left and right bronchi and branch off from the trachea. The main bronchi will divide into smaller and smaller bronchi, and then divide into bronchioles that will deliver the air to the alveoli. The pleura is a serous membrane of 2 layers. One layer, the visceral pleura, will cover each lung. The parietal pleura lines the inner wall of the chest cavity. If the pleural sac is punctured, air can rush into the pleural cavity and collapse the lung. The brainstem. For our control of respiration, we know that the central nervous system controls our involuntary and voluntary respiration via our pons and medulla. The brainstem chemoreceptors are sensitive to changes in carbon dioxide and hydrogen ions in the cerebrospinal fluid. The chemoreceptors in the aorta and carotid arteries are also sensitive to oxygen levels in the blood. The signals of changing levels of hydrogen ions, which can be measured via pH, carbon dioxide, and oxygen, will trigger the respiratory center to send signals through the spinal cord and the spinal nerves to the peripheral nervous system, then to the phrenic and intercostal nerves that will control the diaphragm and respiratory muscles. When arterial blood oxygen levels fall below normal, the respiratory centers in the aorta and carotid arteries will signal the nerves to cause the lungs to inflate more fully, making the person breathe more deeply and at a faster rate. Current research shows that carbon dioxide levels may rise if oxygen is administered, but this is not due to blunting of the hypoxic drive, but instead due to other vascular, ventilation, and perfusion changes. Oxygen needs to be given and titrated to maintain a pulse oximetry reading of 88 to 92%. This is for patients with chronic lung disease, such as COPD or emphysema. Inspiration is inhalation, and expiration is exhalation. Both of these processes occur by movement of the diaphragm and the intercostal muscles in the chest wall. During normal breathing, about 500 mLs of air moves in and out of the lungs with each breath. The diaphragm is the primary respiratory muscle. The diaphragm moves downward during inhalation. When the diaphragm contracts, it moves downward. The other chest muscles will contract, pulling the rib cage up and out, expanding the lungs and creating an area of negative pressure. Air from the atmosphere, which has a positive pressure, will then flow into the lungs. If damage to the spinal cord occurs above the level where the phrenic nerve branches off to control of the diaphragm, or C4, voluntary respiration ceases. A good mnemonic to remember this is C4, breathe no more. If the muscles of the diaphragm and the chest are paralyzed, apnea will occur. The thoracic cage, composed of the thoracic vertebrae, the sternum, and the ribs, will form a stable unit that allows the respiratory muscles to function correctly. Compliance describes the elasticity of the lungs, or how easily the lungs will inflate. When compliance is decreased, the lungs are more difficult to inflate. We can see this in COPD as well as naturally aging. Weakness of the respiratory muscles, which can occur with neuromuscular diseases, will also create a decreased respiratory ability. Kyphosis is the inward curvature and collapse of the spine. This constricts the thoracic cavity and restricts capacity of the lungs to be able to expand fully. Some factors that can affect the exchange of oxygen and carbon dioxide. Surfactant is secreted by cells in the alveoli. It will decrease the surface tension on the alveolar wall so that the diffusion of oxygen and carbon dioxide can take place. When interstitial edema occurs in the lung tissue, the alveolar membrane is thickened and gases cannot diffuse across the membrane as easily. If fluid fills the alveoli, gases cannot diffuse across the membrane. Edema in the lungs occurs with the infectious processes such as pneumonia and in disorders like congestive heart failure. The major portion of oxygen, about 97%, will attach to the heme portion of the hemoglobin molecule. This is carried by erythrocytes and will form oxyhemoglobin. The plasma can also transport a portion of each gas. About 3% of our oxygen is dissolved in plasma. Carbon dioxide can combine with water, forming carbonic acid. Dissociation can occur, which then forms hydrogen ions and bicarbonate ions. About 77% of carbon dioxide is transported in the blood plasma in the form of bicarbonate ions. The remaining 23% of carbon dioxide will combine with the hemoglobin and is then carried to the lungs. The ability of the lungs and chest to move air in and out of the body is called ventilation. This can be clinically measured by our end-tidal CO2, or capnography. Effects of aging on the respiratory system. Aging results in a decreased cough reflex and an increased potential for aspiration. Osteoporosis can cause kyphosis, and this can impinge on lung expansion. Total body water decreases to 50% after age 70. Therefore, mucus and respiratory membranes are not as moist, and mucus will become much thicker. Muscle atrophy can affect the respiratory muscles and diminish their strength. There is a decreased response to hypoxemia and hypercapnia. Trauma or disease can affect structures of the respiratory system, nerves controlling respiration, or diffusion of oxygen or carbon dioxide across the alveolar membranes. Perfusion is essential to provide oxygen to cells of the body. Blood must flow past the alveolar membrane for diffusion of oxygen and carbon dioxide to take place. Inhalation of bacteria and other organisms can quickly produce an infection in either the upper or lower respiratory tract. Tobacco smoke, allergens, poisonous gases, and other toxic substances cause irritation and inflammation of the air passages. This can lead to chronic inflammation, obstructive diseases, and tumors. There are two major types of ventilatory diseases, restrictive and obstructive. Restrictive diseases are characterized by decreased lung capacity or compliance. The expansion of lung and chest wall is limited either by abnormalities in bone structures or by the inability of the lung tissue to expand. Pneumothorax is a collapsed lung. It will diminish lung surface. Neuromuscular disorders can weaken the strength of muscles of respiration, for example, myasthenia gravis, and disorders of the lung, such as pneumonia, atelectasis, and fibrosis, can also increase the stiffness and decrease lung volume. Obstructive pulmonary diseases are characterized by problems moving air into and out of the lungs. Narrowing of the openings in the tracheobronchial tree will increase resistance to the flow of air, making it difficult for oxygen to enter and contributing to air trapping. Therefore, exhalation is also difficult. Asthma, emphysema, and chronic bronchitis are examples of obstructive lung diseases. Tumors in the lung can also obstruct airflow to the alveoli. The best ways to prevent infection and inflammation of the respiratory system are to practice hand hygiene frequently, stay out of crowds, especially during cold and flu season, refrain from smoking, avoid known allergens as much as possible, maintain adequate nutrition, and obtain sufficient rest to keep your immune system healthy. Allergy to airborne substances can cause the mucous membranes of the nose and sinuses to become irritated and inflamed. When these membranes are inflamed, bacteria and viruses can more easily invade those cells and cause an infection. By controlling inhaled allergens, you can decrease the incidence of upper respiratory infection. If you wanted a different look at the classification of airway diseases as far as obstructive and restrictive, as well as lung tissue diseases, you could take a look on page 265, table 12.2. It would be important to understand which airway diseases are listed under airway disease, as well as their classification. It would also be important to know that cystic fibrosis is considered obstructive and ARDS is considered obstructive. So being familiar on that table with your obstructive diseases can be very helpful for your test. For certain groups, such as older adults and the chronically ill, immunization against influenza and pneumonia is an effective means of reducing the incidence of respiratory disease. Healthcare providers, nurses, and others involved in providing healthcare should also be immunized. Current research indicates that in rare occasions, influenza vaccines can increase the risk of Guillain-Barré syndrome. This immune-mediated disorder will occur in about 1 in 100,000 individuals. The vaccine is prepared from chicken embryos, so screening patients for an egg allergy is very important. There are some non-egg formulations currently available. One of the most important preventative measures of lung tissue injury is avoiding prolonged and repeated inhalation of irritating substances. These substances would include tobacco smoke, this would be firsthand or secondhand, industrial gases, coal dust, particulates from agricultural activities, soot and other carbons, and air polluted by automobile exhaust. A complete blood cell count with hemoglobin and hematocrit determinations can be done. This can be done to detect any deficiency in the oxygen carrying capacity of the blood. The nose is inspected for redness, swelling, discharge, and lumps. The hard and soft palates should be inspected, and the mobility of the soft palate can be evaluated by asking the patient to say ah. The paranasal sinuses are assessed by observing for purulent discharge in the nares and by palpating over the sinus areas for tenderness. The most common reason for culturing pharyngeal secretions is to establish a definitive diagnosis of infection with Streptococcus pyogenes, or strep throat. A throat culture is also sometimes taken to establish a diagnosis of pneumonia, tonsillitis, meningitis, or whooping cough. Sputum testing for acid-fast bacilli can be ordered whenever tuberculosis is suspected. Sputum specimens should be collected just after the patient wakes up in the morning. Ideally, a total of 3 specimens on 3 consecutive days should be collected. A test for TB drug susceptibility called microscopic observation drug susceptibility, or MODS assay, can produce results more rapidly and for less cost than standard cultures. There are several blood tests currently available and have replaced the tuberculin skin test used for TB screening in many settings. Pulmonary function tests are useful in screening gross abnormalities of the respiratory system. Complete testing would include measurement of various volumes, flows, resistance, muscle strength, and arterial blood gases. This testing is typically done outpatient. Bedside spirometry testing can also be done with portable equipment, and at a minimum would include the forced vital capacity and forced expiratory volume in 1 second. Patients with asthma or COPD are often asked to check their peak expiratory flow with the use of a peak flow meter. Normal peak flow values for adults are based on age, gender, height, and underlying disorder. Normal values would range from 300 to 700 liters per minute, but are assessed by comparison against a patient's baseline values. When a tumor is suspected, a lung biopsy may be obtained by bronchoscopy or by using a thoracoscope approach or an open thoracotomy. Post-procedure care would include observing the sputum for blood and monitoring vital signs closely. Nothing should be given by mouth until the gag reflex returns. Observe respiratory function when you are talking with your patient and ask about any frequency of upper respiratory infections, any known inhalant allergies, or sinus problems. If the patient is in obvious respiratory distress or is complaining of shortness of breath, just ask a few questions about their chief complaint. Dyspnea is a sensation that is experienced by the patient, and it may not have obvious clinical symptoms. If the patient states that he or she has difficulty breathing, you should use interventions to help make that work of breathing easier. Chest pain can occur with frequent coughing, pleurisy, or trauma to the lungs. However, whenever there is a complaint of chest pain, you must seek additional information and always consider a cardiac problem. Dysphagia can also be a problem for patients with pharyngitis because swallowing will involve pushing food back against the inflamed oropharynx. Hoarseness and a loss of voice are common symptoms of laryngitis. However, hoarseness or a sore throat that lasts for longer than 2 weeks needs to be noted and reported because this could assist with the early detection of throat malignancy. On page 268, look at the red older adult care points box. When assessing an older adult patient, it is important to obtain a thorough smoking history and a history of alcohol intake throughout adulthood. Approximately 90% of throat cancer will occur in people who smoke and immoderately drink alcohol. This is also 4 times more common among men. For the physical assessment, if the patient is not experiencing respiratory distress, you may start your assessment at the head and then end with the lung auscultation. Observe skin color. Cyanosis of the skin is not a reliable indicator of hypoxemia. Cyanosis will occur late in the process of oxygen depletion, and this could indicate problems of circulation or hemoglobin deficiency. However, the presence of cyanosis is always a concern and it will prompt further assessment. Note the posture of the patient, the amount of effort exerted to breathe, the way abdominal muscles and other accessory muscles of respiration are being used, the number of words that the patient can say between breaths, and the rate and character of their respirations. A productive cough will be moist and deep, often accompanied by rhonchi or wheezing, and will end in the production of sputum. A non-productive cough is dry and harsh, and no sputum will be produced. Sputum refers to the material brought up from the bronchial tree. It is not mucus from the sinuses, nasal secretions, or saliva. A patient with COPD may lean forward in a sitting position and use the abdominal muscles to force air out of the lungs. Other indications of difficulty breathing include elevating the shoulders and ribs, tensing the neck and shoulder muscles, and flaring the nostrils. A retraction of the spaces below and around the sternum also can be observed in patients in respiratory distress. Over time, there will be a gradual elevation of the resting level of the diaphragm in patients with obstructive disorders. This will eventually produce an increase in the size of their chest wall. Exhaling through pursed lips can be a clue to obstructive disorders, and patients with emphysema should practice pursed lip breathing. Clubbing of the fingers can be seen in patients with lung tissue or heart disease, gastrointestinal disorders, or genetic causes. Note the number of pillows that a patient uses to prop themselves up in bed, or if the head of the bed needs to be raised to facilitate breathing. This position would indicate orthopnea. This picture can be seen on page 269, showing a barrel chest typical of a patient with COPD. To auscultate the lungs, you first need to eliminate room noise and instruct the patient to sit up if possible, so that the bed or the back of the chair is not interfering with their chest expansion. Listen to 1 full breath in each location. Place the stethoscope diaphragm against the skin with moderate pressure. Move from one side of the midlines of the chest to the other side, comparing the sounds on both sides. Begin above the clavicle and progress downward in the intercostal spaces to above the 6th rib. On the back, start above the scapula and then progress downward along the sides of the spine. then move into the lateral areas of the 10th thoracic vertebrae. Laterally, you should listen in the mid-axillary line in 3 descending locations to just above the diaphragm. Audio clips of normal and abnormal breath sounds are available and are located on the Evolve website if you would like to listen to them. On page 270 in table 12.5, we can see some descriptions of some normal lung sounds. Note that bronchiovesicular breath sounds should be heard over the main stem bronchi, below the level of the clavicles and beside the sternum. Posteriorly, this can be heard between the scapulae. It's always important to listen for abnormal or adventitious breath sounds. Wheezes are a whistling, musical, high-pitched sound produced by air being forced through a narrowed airway. Another type of coarse or sonorous wheezing sound, also known as rhonchi, is coarse, low-pitched, rattling sounds caused by secretions in the larger air passages. Crackles are produced by air passing through moisture in smaller airways. Fine crackles are high in pitch and can be heard in patients who have atelectasis, fibrosis, pneumonia, or early congestive heart failure. Coarse crackles are louder and low in pitch. They can be heard in patients with bronchitis, pulmonary edema, and resolving pneumonia. Fine crackles will sound similar to the sound produced by rubbing hairs between the fingers close to the ear. Check out the clinical cues on page 270. If crackles are heard, have the patient take a deep breath and then cough. Listen again. If the crackles are no longer present, the atelectasis has been cleared. Another abnormal sound is that of a pleural friction rub. This is a grating or scratchy sound similar to creaking shoe leather or an opening squeaky door. This will occur when irritated visceral and parietal pleura rub against each other. This produces pain. The sound and the pain can stop if the patient holds their breath. Stridor can be heard with or without a stethoscope when there is a partial obstruction of the upper airway passages. These sounds are typically heard in children with croup, but can also occur in adults with an upper airway obstruction. It is very important to distinguish between airway swelling and a foreign body obstruction as the cause of the stridor. Presence of stridor always requires prompt assessment and intervention. A patient with chronic hypoxia will move more slowly. They will take more time to answer questions and have less energy. Working with patients who have dyspnea will require planning extra time in order to accomplish their treatments and care. Effectiveness of interventions for and treatment of patients with respiratory disorders is based on improved breathing pattern, pulse oximeter readings, arterial blood gas values, and lung sounds. Decreases in coughing, sputum production, wheezing, and signs of infection are other parameters that can indicate improvements. Reassessment is an ongoing nursing activity for patients with respiratory problems. And we can see this picture on page 271 showing you the sites for auscultation of the lungs. Notice the arrows. It's showing you that you want to go back and forth across the chest for that comparison of lung sounds in each location. It's a very important aspect of listening to the lungs. Coughing can be beneficial and should be encouraged if it is effective in clearing the air passages and removing accumulations of stagnant mucus. If coughing is excessive, the patient can tire and the respiratory tissues and thoracic structures will be traumatized. So antitussive agents may be used in order to inhibit the cough reflex in the cough center of the brain. Liquefying agents of cough syrup and dilutants The liquefying agents and dilutants will help thin secretions and help the patient expectorate. Adequate hydration is the most effective method to liquefy these secretions so that they can be coughed up. Water should not be taken immediately after a cough syrup because it will rinse off the topical application of the medication. In bacterial infections and chronic respiratory diseases, the sputum often is foul smelling, leaving a bad taste in the mouth and an offensive breath odor. Frequent mouth care will help remove pathogenic microorganisms from the oral cavity and therefore diminish the possibility that they will be aspirated deep into the air passages. Mechanical suctioning is indicated when the patient cannot clear the airway of excessive amounts of secretions. However, deep tracheal suctioning, whether through the nose, mouth, or ET tube, should only be performed using strict aseptic technique and by somebody experienced in this correct procedure. Remember that suction passes should not exceed 10 to 15 seconds. And remember that patients should receive mouth care after suctioning. The need for suctioning will be based on patient assessment. The purpose of suctioning is to facilitate breathing and allow for an adequate exchange of carbon dioxide and oxygen in the lungs. Even though the procedure may be necessary, suctioning does remove oxygen, and it is very uncomfortable for the patient. For patients with dyspnea or breathlessness, use a calm manner and assure the patient that everything possible is being done to bring them relief. A high Fowler's position is best for patients with dyspnea. For severe dyspnea, the orthopneic position can be most effective. Orthopnea means that the patient has trouble breathing when supine. The patient should sit upright, lean over their overbed table, and elevate and round their shoulders to allow for maximum expansion of the lungs. Pressure from organs, fluid, or tissue below or near the lungs and diaphragm can impair breathing, and obesity is a risk factor for dyspnea. Dyspnea may or may not be a result of hypoxemia. For oxygen to reach the tissues, the patient must be breathing adequately, have a patent airway, have lung tissue able to exchange gases, and have adequate hemoglobin to carry that oxygen and adequate blood flow to deliver the oxygen. Alteration in any of these can affect delivery of oxygen to the tissues. The tissues most sensitive to changes in oxygen levels would include the brain and the heart. Therefore, clinical signs and symptoms of hypoxia will show up first in these organs. Alterations in brain function would include restlessness, anxiety, and confusion. If hypoxia is not identified and corrected, the vital signs will then be affected. The heart rate will increase in an attempt to increase the oxygen delivery. Blood oxygenation is monitored by pulse oximetry, and an SpO2 of 92% or less at sea level will suggest hypoxemia. Ventilation is the movement of air in and out of the lungs. The body's ventilation ability can be measured by our CO2 levels. Capnography is the measurement and display of CO2 levels. Hypercapnia, also called hypercarbia, is the retention of excessive amounts of carbon dioxide. This is the result of hypoventilation, during which the usual amount of carbon dioxide is not eliminated via exhalation. Hypocapnia is a deficit of carbon dioxide. This can occur as a result of hyperventilation and can result in respiratory alkalosis. Conditions associated with hypocapnia would include those in which there's an increased metabolic rate, such as thyrotoxicosis, persistent fever, and acute anxiety, salicylate overdose, and improper use of mechanical ventilation. Respiratory failure. Carbon dioxide is a respiratory stimulant. Hence, the body will respond to excessive levels of carbon dioxide by increasing the rate and depth of respirations. Respiratory failure can be defined by an arterial blood gas, an arterial oxygen, so PaO2, below 50, and the partial pressure of carbon dioxide is equal or greater to 50. Cardiac arrest can result from respiratory failure due to hypoxia and acid-base changes. Diseases, trauma, changes in neurologic function, and metabolic disorders can all alter breathing patterns. Many acute upper respiratory infections are transmitted by droplets. That is, the causative organisms are expelled along with the liquid secretions released during coughing and sneezing. Diseases that are spread by airborne contamination have organisms that remain suspended in the air for long periods and will float on air currents. Avoiding crowded places, performing frequent hand hygiene, and keeping the hands away from the face and mouth can decrease the likelihood of infection. Hand hygiene should be implemented after each contact with a person with a respiratory disorder that produces airborne or droplet secretions, after removal of personal protective equipment, or after contact with any articles contaminated by secretions. Anorexia and inadequate nutrition are common in patients with respiratory disorders, particularly when these disorders are chronic. Keep the patient's environment clean, uncluttered, and orderly. Dispose of any used tissues promptly. Frequent oral hygiene and mouth care before meals can help improve the taste as well as diminish mouth odor and nausea. Because there is increased energy expenditure when breathing is difficult, many patients will have difficulty maintaining weight, even when they're taking in normal amounts of calories. When a patient is receiving mechanical ventilation, caloric needs will also rise. A fluid deficit is likely in patients with respiratory disorders because there is an increased loss of fluid in respiratory secretions. Unless contraindicated, an intake of at least 3,000 mL of liquid should occur each day. This intake should include low sodium bouillon, fruit juices, and other liquids in addition to water. Humidifying the air breathed by a patient is an effective way to minimize dehydration and moisturize the air passages. Humidification is especially important for patients whose secretions are thick and tenacious and difficult to cough up. Hypoxia will produce a loss of energy because it causes a disturbance in cellular metabolism. Patients with respiratory disorders, whether acute or chronic, will have some degree of intolerance to physical activity and therefore will need periods of rest throughout the day. To conserve energy, the patient should intermittently take short naps. The goal of nursing care should be to achieve a satisfactory balance of rest and activity.